denoted with impingement. Number 1 is your supraspinatus tendon. Number 2 is your biceps tendon. And number 3 is the subacromial bursa. Now, just break that word down. That means it's below the acromion. So the acromion is also involved, but it's not a soft tissue. In fact, what we know is that some people develop an intrinsic impingement based off of mostly, and let me just get you on the same page here. Mostly because on page 561, it talks about a change or modification occurring at the musculotendinous unit. So maybe that is some type of degrading occurring with specifically the subset of the supraspinatus. That's not really the one that we hear about most, though. If you turn the page to 562, the one we hear about most is an extrinsic impingement. And that one comes from either primary or secondary reasoning. Now, to kind of catch you up here, primary means that it came on with idiopathic reasons sometimes. I mean, it just comes on. However, sometimes primary means because of something we do repetitively, it came on. Secondary would mean it came on because of maybe I had a shoulder trauma, like a dislocation, and that caused a sequence of events of inflammation to come on, and that caused my impingement, right? And those are described more in 562. Also, a primary could be from this stuff right here. And this is the type 1, type 2, type 3 classifications of the acromion. And this is really consistent through all literature types, that type 1 is just kind of a flat. And type 2 is just kind of a curve, where type 3 you see is defined as a hooked acromion. And what will happen is a person they'll start developing shoulder pain. They'll go see their orthopedic doctor. The orthopedic doctor, the first thing they do is take an x-ray. And if they see in the lateral view that there's a type 2 or a type 3 acromion, then what that does is that just predisposes to certain degrees of greater likelihood that you have a primary impingement, or a primary extrinsic impingement. So you're following that one? Because the type 2 and the type 3, they create more of a compression area over, remember, the bursa, the supraspinatus, or the biceps tendon. So we gave you some other pictures down here. This one right here is a picture of a dislocated shoulder. And we're going to talk more about that here in a little bit. But when a person does have a dislocated shoulder, it just causes a sequence of events in inflammation that could cause an impingement syndrome to occur. And then also this stuff right here. Take a look at this guy's external rotation. Anybody in here have remotely close to that level of external rotation? And the answer is just straight up no, you don't. Like, this guy's playing the major leagues. I mean, he can throw a baseball hard, but he can also, and this is the name of the phase, he has external rotation in the cocking phase of his pitch that is almost unhuman, right? I mean, like, that is grotesque by all descriptions. So this right here also indicates that we could be inflaming some tissues, and this is really what we see. And if you look at the next page, it talks about something known as internal extrinsic impingement. And it's primarily involved with throwing athletes. and it occurs in a position of elevation. And so elevation by the book's definition is flexion, abduction. Okay, that's elevation. Horizontal abduction and maximum external rotation. I would say that that fits the bill for those three words. And so if you're still kind of curious here and you're like, I'm not quite picking this word up. Okay, so impinge sounds like pinch. And the acromion and the humeral head, that's what they're doing. They're pinching any one of those three structures. And so that's kind of how we're going to live with that whole concept. Now, that being said, I'm going to skip to the next slide just so you can kind of see this. These people have positive impingement signs. So I'm going to come over here and I'm going to show you. Do you remember how we took a patient a few weeks ago and we pushed up like this right here? And we said that's impinging, right? And we talked to you about the three tissues at that time. And then we took and we internally rotated a deducted across the body, right? And what are we doing there? We're impinging. And then this morning, we talked about the most impinging position being that of empty can, right? So all three of those kind of come together and culminate for this thing called impingement, right? And again, what are the three structures? Tell me again. Supraspinatus, biceps tendon, subacromial bursa. Those are the three impingement soft tissues. Two bones involved. What are they? Acromion, humeral head. Yes. Now, just so you have some clarification, I did skip over the two specific instabilities up there on page 563. We're going to come back and visit those later this morning. But not from this direction. We're going to go a different one. All right, so real quick, some other things. Some tendinopathies. I also, if you'll notice kind of how I structured this, I said tendinitis because the book says that. I got a lot to say about that, but we're going to hit that later. Opathy is kind of where I'm going with that. So you can have this happen at the supraspinatus, the infraspinatus, the biceps tendons. And also, you can just have a bursitis. It's not really impinging or impingement, but it is impinging. Does that make sense? Because the bursa swells, especially the subacromial. If it swells up, it feels like they have an impingement. But as soon as the bursa goes down, symptoms resolve. And that's sometimes as simple as an injection. And so it requires little of us. These other three, though, take a look. You have the supraspinatus. If it gets inflamed, the tendinitis or tendinopathy, then they develop a positive impingement testing, which again is here, here, or here, right? Those are the Neer's impingement test. Also, we look at the full can treatment here. This is okay. This is not, right? And that's where that whole precaution comes from. So remember, you can do full can, cannot do empty can. Also, I have there, they have a positive supraspinatus test. Shikari, may I borrow you for just a second? Everybody kind of come on up here. Face your peers. Yes. Okay, so here's your supraspinatus test again. We talked about this one. It is the empty can position in the scapular plane. And then, what are you doing? And then I will manually muscle test here. So you resist me, right? And what happens here is if he has a positive test, oh, that hurts. Oh, please stop doing that. You're torturing me, right? He won't let it happen. And so that tells us, let's not do this treatment either to fix that problem. Like countless PTs and PTAs went years saying, well, we're going to do our empty can exercises here. And the patient's like, I'm just not getting better. Why? Because it's an incredibly impinging position. Infraspinatus. My golly, you guys already nailed this one earlier. What does it do? It does internal rotation or external rotation? External rotates, but look at here. It's from an eccentric internal rotation. Now I want you to watch that again. Some of you weren't looking. It's from an eccentric internal rotation. So overhead throwing athletes, they develop an infraspinatus tendonitis. And they say it hurts in my follow through from that eccentric slowing down from the infraspinatus. And that's a really easy muscle to identify because where is it located? Below the spine of the scapula. Remember how easy that one was to palpate? Biceps tendonitis, the transverse humeral ligament. Learned that on day 1 of seminar, didn't we? Maybe day 2. I don't remember. Here it is right here. Biceps tendon goes between these 2 little bony prominences known as the interbicipital groove. The ligament lays right there. And that's where their pain is. But listen, if I put my finger right here on your shoulder, on your arm, you're going to think, oh, that's shoulder, right? And it is. It's right there. And so what does it look like? It looks like shoulder pain. It has a Speeds and a Jurgensen's test, which are largely a concentric activity of that biceps muscle going into shoulder flexion. And when it's painful from doing that, we can say biceps tendon. Here's the problem. You may not be able to diversify all of these things right here and say it is this or it is that. Your treatment, though, is the same. Turn the page and let's see. All right. So, page 564, it jumps in and it says, there are some painful shoulder impairments. Impairments. That means these are things that show up because of the problem, right? And so this is just a really good time to teach some of this again. Number 1, they're going to have bad posture. You saw that picture at the front of the chapter. What did that guy have? He had a big kyphosis. What were his scapulae doing? They were protracted, right? The pec minor was like contracting like crazy. Remember all of those good things? Decreased thoracic range of motion. They overuse their rotator cuff. Here's another one. They have muscle weakness and neuropathy. And then you have this picture of this young lady right here. And what do you notice about this young lady?
Scapular winging.
That's right, scapular winging. All right, I think the curry's on it. You ready to eat this Cheeto, baby?
Yeah.
What causes scapular winging?
Long thoracic nerve.
A long thoracic nerve palsy or compression or injury. And then it's what muscle?
Spray sensory.
Right. Because if it's weak, what happens? The strong side, your protractor is weak, so your retractors pull it up. And that's what you see. You may have that problem as well, right? And that's just a really good picture right there of what happens. You can really pin those out pretty fast. Most of the time that test is not from that position, it's from this one. And they do that, and you'll see one scapula just crazy hanging out there. Lastly, hypomobile posterior joint capsule. Let me back up for a minute. Take a look at my picture right here. I would argue, now catch my words here, that he has a grossly hypermobile anterior joint capsule. Wouldn't you agree? All right, so this population, especially overhead athletes, whether they throw or use a racket or whatever, they get this hypermobility here. But then here, it tells us one of the things that they will get is a hypomobile here. They're really hypomobile. We gave you a stretch. Dakari did this. He laid on his side, he put his arm out here, grabbed here, and put down. What do you think that stretch is? The posterior joint capsule. So that's your solution to that problem. All of those are listed there on 564, 565. Jumping into some common limitations. This is probably true about all kinds of shoulder stuff, so just kind of keep this going here. They have pain that interferes with sleep. That's almost always what sends a person to the doctor. Lindsay shows up tomorrow morning and she's like, I haven't slept all night. And she looks like a wreck and she's like, oh, I just feel terrible. Listen, if you've ever lost a night's sleep and then it happens on a continuum, you're ready to get some help. And if that's from shoulder pain, that's probably a good indication that you need help. Pain with overhead reaching, that right there. So Noah, he's doing a lot of bench press and he says, man, I can't do military anymore. I can't even lift up, grab something out of my cabinet, right? That could indicate impingement. It could indicate that there's a tendonitis, a bursitis. These are activity limitations. Difficulty lifting a load. They have pain in the shoulder from that. Inability to sustain repetitive shoulder activities such as reaching, lifting, throwing, pushing, pulling, or swinging the arm. And then finally, difficulty with dressing, particularly putting on a shirt on overhead. Those are just some things that you might be patient educating about. Listen, this is going to happen through this phase of healing, but it's going to get better, right? So these are the things that we see people improving from. Over here on the protection phase, remember, this is not a surgical group of conditions. So it says modalities, support the arm, talk to them about pain-provoking activities and how to avoid them. So right here, control that inflammation, patient education, maintain mobility. How do we maintain mobility? What's our technique?
Range of motion.
What kind?
Passive.
Passive. Exactly. So we're doing passive range of motion. Might that mean Codmans? Yes. Might that mean wand exercises? Yes. Because remember, passive is within what's available. How about this next one? Controlled motion phase. We're going to balance in length and strength. Now I'm gonna scratch a really nasty scab. And so I'm gonna move over here furthest away from Kamishi so in case she throws something at me. If your pec minor is tight, that's something you're gonna have to add length to. And if you want to strengthen the pec minor, you gotta strengthen it in a lengthened position, right? So that means maybe we take a roller and we put it right here, we lay them on that roller, and look, there's a strengthen and a lengthen, look at it, right? And we lengthen that pec minor out, and then we strengthen it, right? We have to balance our strengthening and lengthening. Another thing it says, and this is over on page 566, stretch those shortened muscles. Okay, everybody looking at me. It's nowhere on the book. You can't find it in the book. You're going to have to look at me. And then you might look around. Perform a pec minor stretch. Go. And throw your books down while you're doing it. Right? Hang on. Let me show you Terrace.
I'm freezing.
Now, everybody show me a pec major stretch. Pretend there's a wall or a door frame or whatever, right? Very good. Now, do me a favor. Turn to page 593. Hold your place in that. Just go to 593 real quick. On figure 1730, this stretch that we just did for the pec minor, it says right there, pec major. Alright? I want you to know, yep, I think you could feel that stretching your pec major. Noah has a really good set of pec majors. I don't like stand there and gawk at your pec majors, but I'm just telling you, I've noticed you got a good pec major. It's good, it's good. A little jealous. I'm never gonna have that pec major. But when you did this, did you feel that stretch in your pec major? Yeah. Okay. But what I'm gonna continue to press into is this is a pec minor stretch, and here's why. Because it's possible that someone has leaked information that they saw a picture of that one time. And I'm not gonna tell you where, but if you don't know what I'm saying, just trust me. Got it? Has nothing to do with my test either. If you can't take the hint, then I'm sorry. Strengthen and train the scapular stabilizers. Okay, again, what are the scapular stabilizers? That's anything that compresses, elevates, protracts, or retracts. Right? It's just stuff that we're doing anyway. So if you take all this stuff we did this morning and you just lump it back over for a biceps tendonitis, for a supraspinatus tendonitis, for an infraspinatus tendonitis, all that goes in. And then you look at strengthen and train the rotator cuff muscles. Dakota, you owe me one good rotator cuff strengthening technique. Go.
Isometrics. Wait, no.
Deflating.
Bands, external rotation.
Okay. He reflated me. Dakari, this was terrible. What did I just do that for? Give me another. Come on.
External.
Okay, there you go. Give me another. I'm still at 2. Come on. I gave you 5. No, come on now. I gave you 5. I said this protocol gives us 5 things that we're going to be able to call on quickly. Internal, external rotation. Probably got that flipped. Strike it, reverse it. What do you got? Put a rubber band in your hand. I got flexion. There's 3. What do you got? Extension, abduction. Boom. So there it is right there. And you just carried everything we did this morning. Boom. And you dropped it on there. It's just where do you fit that puzzle piece in, right? But there you go. So clinically, you're ready to go. Right there on that one. Then it talks about some of those other things that we can do, including closed chain stabilization. That's shoulder taps, right? Or knee taps, right? Or reach throughs. All those are awesome. Do those closed chain things. Weight bear the shoulder. But when you do, what are some cueing things you've got to do to get that patient to weight bear appropriately? Got to lock that elbow. Got to stabilize the wrist, right? Protect them, guard them. All good. Questions to that point?
Where are you at in the book?
566 at the very bottom, on the right-hand column,
Okay.
closed chain stabilization.
Okay.
It was italicized. All right, so I'm going to go ahead and move over to the return to function phase. But I just got really one thing to say there, and that is, how do we do functional training and quick motor responses? Quick motor responses, think plyometrics. Am I saying that they should be able to do plyometric push-ups or where you push up and, I'm forgetting the name. There's another common name, help me out. Where you push up and you actually leave the floor and you catch yourself. I can't think of the name of those. I'm lost. What I'm going to do is I'm going to throw you out one, like, really kind of like gold standard for eccentric and plyometric together, and that's called a thruster. I'm not saying you should do this with a lot of your patients, but this is a really good one because it teaches the whole idea, then you take and modify it down. A thruster is simply loading here, and when you squat, you come up with a weight that's probably too heavy for you to do just that alone with, but the momentum of the squat thrust up throws the weight up, and then eccentrically you have to control it down, right? So in this phase, it kind of brings all of that together with the quick motor responses on 567 over to the functional training, really emphasizing eccentrics of the shoulder. There's one other that you've seen Bill do a lot. Maybe you haven't, and if you haven't, I really regret this. May I borrow you again, Dakota? I just know Dakota doesn't have any crazy arm issues. I did dislocate a kid's shoulder one time in a demonstration, and I don't want to do that again, so. All right, so tell me what I'm doing here, Monica.
D1, flexion and extension.
Say D1?
Mm-hmm. Wait. Yeah.
Wait on what?
Never mind. Just
Do
kidding.
you think I should wait? Did you like her answer?
Yeah.
So does she owe me $100 now for trying to change her answer?
But you looked at me like I was wrong. I had
That sounded like a question to me.
It wasn't my eyes, it was the mask. You just didn't see. Okay. So here I am doing D, what?
1.
Are you sure?
Yeah.
Okay. D1, flexion extension. Now I add in some eccentrics with that, right? By basically saying, okay, you're here. Resist me as I come down. Good, now resist me as I come up. Good, and this is terrible positioning for all of this, but again, we don't have a table, right? And so he is eccentrically resisting those movements, right? Then I double down and I say, okay, resist me, but we're going fast. I mean, you should have seen Bill Carroll doing this, man. He was like, and these poor old baseball players are just, you know, it's good though. Whew, what's my pulse? Here we go. Let's talk about this one. If impingement is so bad they can't fix it with therapy, they call on the surgeon. Surgeon says, that's what I wanted to do in the first place, because you know what surgeons do? Surgery. That's what they want to do. That's where they make their money, right? So here's the surgeon. We're going to do a subacromial decompression. Right? That word decompression opens up. Everybody good with that? You hear that word decompression, you say, I'm going to open it up. So this is for impingement. And your book shows a picture of something called an acromioplasty. But there's more. The acromioplasty can be found on 568 at the very bottom. They're going to go in there and they're going to chop off some of that acromion. See it there. One of the other things, though, that we want to show you is some other procedures that may come in that are also associated with, but sometimes left as just the name subacromial decompression. So you may not know exactly what the head had done. They got their hair did. So this is it, 568 procedures. Take a look at these bullets. They may have had the subacromial bursa removed. Do you see it there? On the first bullet. The second bullet, they may have had a coracoacromial ligament release. Help me out. What is the coracoacromial ligament? Could you go show me?
No, I don't want to do that.
Why do you not want to do
I don't know.
that? Fear?
Maybe.
Come on. I'll help. Come on. You can bring your Gardettos. What'd you say it does? Okay, lay it on me. I know that. Show me the coracoid.
No, I don't know now.
Yeah, you do. It's that stupid bone right there.
I'm I was literally about to do this for you, so.
That's the clavicle, and that's the acromion. So that ligament looks like that right there, right? You guys with it? If you didn't, come check it out. That ligament, it's there, and it holds some things down, and like two bones that don't move. This is what's crazy is the coracoid, the acromion, they don't move. They're both like fixed on the scapula, but there's a ligament right there. And so they can go and whack that dude and opens up space. Again, it's a decompression, right? Take that bursa out, it opens up space. It's a decompression. One more, they can resect the anterior acromial protuberance. Which is basically that red line right there that takes that, or that red space right there on the acromion. And it's also known as a acromioblasty. A fourth bullet up at the top. Every once in a while, these people will get something called an osteophyte developed between that, a subacromial osteophyte. What's an osteophyte? There you go. So guess what they do? Take out the bone spur. Decompression. All of those. Decompression, decompression, decompression. So, immobilization. Take a look at that on 568. A sling is worn for a couple of weeks. But take a look at what it also says. It's removed daily for exercise, like the second day. Right? These people are coming in pretty quick. So what I would do is I'd take all my shoulder surgeries here. I'd say sling, sling, sling. And then I would say from this one right here, they're coming out pretty fast. Is it possible that they don't get there the next day? Yes, because of insurance and logistics and who knows what. This may be 3 or 4 days down the road. Maybe they had their surgery on a Friday. They didn't come to therapy on a Saturday, right? You see what I'm saying? So is it always going to be on day 2? Who knows? We're just telling you that it starts pretty quick. Their max phase. Take a look at their goals. And you're going to see just a lot of consistency. Control the plane. Use a sling. Cryotherapy. That's ice. Active range of the cervical spine, elbow, wrist, and hand. Now I want to just give you some parentheses to put in your book. Put parentheses over elbow. Active range over the cervical spine, scapula, wrist, and hand, and elbow. Elbow is big because it is not always given authority for active range in a solar surgery. And that will pay off next when we talk about our rotator cuff. They can start in a lot of active movement. It's talked about in restore pain-free shoulder mobility, but that may be dependent on what the doctor says. So we're going to start them at passive and then slowly move them to active. But I want you to make a note here that in the max protected phase, it can be a little more aggressive than other shoulder surgeries. And that is because they don't do as much. A decompression is not as aggressive as the total shoulder, the rotator cuff, the bank heart, all those others that we talked about. So just keep in mind, they can be a little more aggressive in the max protective phase. It talks about your isometrics. And then over the moderate protective phase, I just want to read this bullet, and I want you to tell me how we do it. restore and maintain full pain-free passive mobility of the shoulder, girdle, and upper trunk. How does one restore mobility? One word. Stretch. And what phase does that happen in? Every time. I'm not going to burn you down on everything else there because it's really a lot of taking, just like we did before, everything this morning and piecing it in there, right? Your strength and endurance, you stretch the same things, you strengthen the same things, you pay attention to the same things. It's just, you can be a little more aggressive with this one than you can the last one. Let's now talk about this.
Rotator cuff.
The rotator cuff, the rotary cuff,
Rotary cuff.
the rotary cuff. And your patient says that, you just kind of,
I had a rotary cuff patient,
Yeah.
last week. I
the
think
question
my
is
rotary
though,
cuff-
was he a close talker like this? Those are the ones that wear me out, 'cause I'm already gonna be up in your grill and they like, and I'm not a close talker. There's this, you missed out, man. We had a patient, he was a shoulder, that's rotary.
person
He's a close talker. And you know what, I go to church with him, and every Sunday he's like, hey, Kendall, and I'm like, oh gosh. Great, you know, they're starting stuff. I'm like, oh, you got time. No, I don't. It's just weird, man. And then I'm like, hey, you know, we got this thing called COVID going around, you know, back in. It's not. Yeah, he's a close talker. He's a good guy.
I saw him at Walmart a few weeks ago. That's
Did he talk to
everything
you?
he done was came to me. You been in trouble lately? Like this close.
He's super. I love him. His rotary cup. All right. So the tear types. Got to know this one. This is an academic. You got to know. All right. So they grade these, and it starts it out on 570, talking about a partial or full thickness. But that doesn't tell the whole story. So go ahead and turn over to page 570. 2-3, down at the bottom, table 17.5, and this gives us a little bit better. All right, so you have a partial or a full thickness tear. Your small is less than 1 centimeter. Your medium goes from 1 to 5, and your massive is anything over 5. I want to apologize to you guys. I know how crazy it is. You're trying to cram every bit of this in, and we keep throwing these different numbers at you. I get it. I hope I'm able to connect the dots on this one with another item later, and I think I will be able to. So give me some time. But your small is less than 1. Your medium is 1 to 5. And your massive is over 5. Now let's go back and let's see what this says. A partial thickness tear extends inferiorly or superiorly through only a portion of the tendon. And a full thickness is a complete tear, which is the whole depth of the tendon. These are two different definitions. You could have, like in this picture right here, that is a full thickness tear, and clearly probably goes more than 5 centimeters by virtue of where it's at. You have a length discrepancy, but then you have a depth discrepancy. And so that's what you're looking at there between those two definitions. I don't feel like that's going to be a big deal to you test-wise, but logistically speaking in the clinic, I think you may need to know that. 3 types of repair. On the procedures, you have your arthroscopic. So that means I'm the doctor, I'm the surgeon, I walk over here, I've got this big shoulder taped off, and I cut a hole here, here, and here, and I have portals, right? and I shove that arthroscope into the joint and I do my repair. Probably gonna be a pretty insignificant tear to repair at that point. Then they have this thing called a mini open or arthroscopically assisted. And then you have your traditional. And that means they're gonna make an incision. Those incisions aren't that big. However, my dad had a rotator cuff tear when he was young. And so this would have been in the 60s. He had a scar, and I'll never forget it. Like, it was like such a manly thing about my dad. I mean, there were many manly things about him, but I remember this scar on his shoulder, and it was like, it had a depth to it. It was very different, but it went from here all the way across. And my dad grew up in this era where everybody wore wife beaters, like it was the onset of wife beaters. And so I just remember as a kid growing up and always seeing the scar. And he had pretty muscular arms for a guy at that time, but he had this big scar, and I was always like, man, I need a scar, right? It's cool. So that was that. I just talk about that because that's that traditional open approach, and how it, today it's just not that big of a scar. It's fairly small, in fact. Some concomitant procedures. 571. Underneath components of a rotator cuff repair. The second paragraph, it says many times you're going to see these associated with the subacromial decompression. Sometimes they'll tighten or do a labral reconstruction. Also it says, because degenerative changes in the tendon of the long head of the biceps brachii are often associated with chronic RC disease, a repair of this tendon also may be necessary. All right, so a minute ago I said subacromial bursa, you can do elbow flexion. You can do elbow extension. Rotator cuff repair, you've got to be on your toes right here, because many times the biceps tendon is involved, and if they have to do any type of repair up here, here's what you can't do. Oh, listen, Kendall always said do adjacent tissues. So we're going to do your neck, we're going to do your scapula, and you know what? I'm going to be an A student here. We're going to do your elbow. And you just broke protocol on the rotator cuff because you can't do the elbow if the biceps tendon is involved. That goes to the same degree of saying, oh, you had a hip replacement. Let me go see what your weight-bearing status is and not assume that you were cemented, right? You've got to go verify. If they have a biceps tendon involvement, usually it's called a tenotomy. If that was involved, you can't do biceps early. You can't do elbow flexion early. So big precaution there. It's not in your book. This is a clinical pearl. It is in your book, but it's just not right there. So I'm just going to keep rolling.
We would write down tenotomy with rotator cuff.
Don't worry about the word tenotomy. Just worry about, is the biceps involved? All right, mobilization. Sometimes you're going to see them roll in a sling that looks like this right here. It's got a swath. You see that going around her trunk? But it has something else. It has a pillow. Anybody know what that's called? It puts them in abduction, and it's a pillow. Guess what it's called? It's an abduction pillow. It's an abduction sling with a pillow. And sometimes that's how they'll have it. Now think about this. Put this in your mind fourth dimensionally. No, do this third dimensionally. Okay, if that's torn, I want to shorten that. And so what they'll do is they'll put them in an abduction pillow, which will hold them right here, which shortens that rotator cuff, specifically the supraspinatus, which is the most commonly torn rotator cuff, by the way. And guess what that does? That allows for healing to take place better, right? And then this process may last 6 to 8 weeks. And that's in the next bullet, but also in your book. Take a look at this for me so that you see it. Under immobilization, no, I'm sorry. Go to max protective phase on 575. this could last 6 to 8 weeks. Now, I made you a promise at the beginning of Ther 2 that you wouldn't have to know all kinds of dates or time durations. This is one that you gotta know. If they have a massive tear, they're not doing much for 6 to 8 weeks. In fact, go backwards in the book to 574. If they have a full thickness massive tear, it says early shoulder motion. Perform passive or assisted shoulder range of motion within a safe, pain-free, based on the, and here it is, physician's preference. Only it says surgeon's intraoperative observation. Second bullet says only passive motion for 6 to 8 weeks. So you know what you're doing? Everybody's looking at me like they don't know where they're at. You know where I'm at? No?
We're skipping around.
Box 1710. I know, I gotta move fast.
Do they worry, about the scar tissue kind of restricting the motion of the work of his hand?
That is a really good question. Did you guys catch that?
No.
Okay, she said, do they worry about the scar tissue? I'm telling you, you're in an absolute dance with it's a square dance. And you're going from this surgeon to this surgeon over what they're gonna do on scar tissue, right? And I guess it probably depends on the patient too there, but like some surgeons, they want them in this abduction pillow for 6 to 8 weeks, and they may even say no passive range. Don't touch it. They may lock you out for 6 to 8 weeks because they want that much scarring to happen. And with the shoulder, it's all about building stability, and sometimes they let scarring take over that process. And then sometimes they're like, no, do your passive range. And then, I gotta be honest with you, you'll be 3 or 4 weeks in, and the PT will call you and say, why haven't you started doing isometrics with this patient? And you're like, because they're 6 to 8 weeks before they can do that. And you're like, no, they want you to do that. Well, then you told me. Right? I mean, it's a, who knows? Who knows, really? But that's a great question. Back to box 1710, that's over on page 574. Passive range only, it's the second or third bullet there for 6 to 8 weeks. So your default is passive range only on the big tears. So when we did passive range earlier, you did that in the supine position, right? That helps to stabilize the scapula so that the movement is only at the where? Glenohumeral joint, right? Once you're pretty free of that, I like to have them sitting. They're much more comfortable. The problem is you're going to start getting a little bit of scapular, but you know what? You want a little bit of scapular at that point. I want you to take some time and look through the rest of that box right there. But I want to jump in over here on some of the specifics. Control pain and inflammation. Just real quick for me. Look at those 4 things. Prevent loss of mobility of adjacent regions. I'm on 575. Assisted range of motion of the elbow, not active. Active range of motion of the cervical spine, wrist, and hand. Do you notice that? That's a critical moment. That's like, the book doesn't say it, but it says it. Don't do active elbow range. Lock me out. Dakota did. Take a look at preventing shoulder stiffness. Here you go. Here's what you can do. But you can only do it until you can. Passive range. It says pendulum exercises. Typically the first post-operative day, but sometimes the doctor says no. You just got to check the medical record. You got to know. And I'm sorry, there's not a clearer picture than that right there. Sometimes yes, sometimes no. Take a look at the third bullet. Self-assisted range of motion using the opposite hand or a wand for control by 1 to 2 weeks. Until sometimes they say, nope, don't do it. And it all depends on the severity, their age, what the doctor believes they should be able to do. I mean, there's just so many circumstances that we can't control there. And then over here, precaution, use only passive for 6 to 8 weeks for repair of a massive. Posture training, scapulothoracic stabilization. It says there we can do active movements of the scapula. Think about this. Think about how the rotator cuff comes through and it basically wraps around that humeral head, right? And all of those muscles have origin off of what bone? The scapula. But we can move the scapula. Okay? So that means they can do this, and this, and this, and that, and that, and that, right? So, let me paint you another picture. You guys have become uber aware of this whole like treatment duration concept. The minutes, the rugs, what's you gotta have to bill for. Like all of a sudden you're aware of this now. You're in the real world that I'm not in. Right? I can talk to school all day. You guys have a much deeper appreciation. So you say, well, but Kendall, this doesn't make sense. I'm gonna do passive range of motion on the shoulder and I'm only gonna be able to be in there for 15 minutes. And I gotta meet it for 45. It doesn't work out. How do you build the rest of that time then? You bring in your modalities. You bring in your massage. You bring in your scapular movements, your cervical movements, your wrist movements, right? You bring in the other side that wasn't repaired, and you do your eccentric, concentric actions off of a TheraBand. I should have said that in reverse. Using the Rockwood protocol, right? And you get the carryover concept. All those things, that's how you build your whole theory up, right? So don't sweat it that we can only do passive range. Just get creative and think, okay, I can do other things, right? What else can you do? That's what separates you. That's what makes you a therapist. And then finally, it says isometrics. Begin as early as 1 to 3 weeks post-operatively, depending on the size of the tear. So that's where that 3 weeks comes from. And that's literally been something that's happened to me. I've been driving down the road, going to my next patient's house, and I get a phone call. Somebody who's in the office next to me, and she says, why have you not started isometrics? I'm like, it's week 1.5. And here's the other thing. You want a money ticket? You get a home health patient who's just had a rotator cuff repair. Because you got to see them 5 days a week almost. That's a lot of visits. For the first roughly 6 to 8 weeks, you go see them 5 days a week. It's a gold mine, since we're talking about that kind of stuff. Precaution, and this is where we're going to stop. Precaution says recommendations for the safest position of the shoulder in which to begin isometric training of the glenohumeral musculature after a cuff repair are inconsistent. But perhaps the safest suggestion is to start in a position that creates minimal tension on the repaired cuff tendons. The shoulder is internally rotated and flexed and abducted to about 45 degrees, and the elbow is flexed. Right? Okay, that's this. Looks just like if they were wearing the abduction sling. So that's what you would use as your point of reference. So this morning, I saw some of you, the way you were starting, some of you had them right here, some of you had them out here, it was just variations. So we put the pillow in, or the towel is what we did. Gave them a little bit of extension. Did it give them enough? Maybe not, but it was a good start. We get them out here to about 45 degrees. We internally rotate them to about 45 degrees, and there's your starting point for your isometrics. Alright. So, I'm gonna start spraying this thing with water. No, we have not completed the shoulder yet.